After watching my first acute care eval, the video that was posted, I wrote down a few of the things that I would like to improve on going forward. The first thing that I had was my bedside manner with my patient. So upon entering the room, the patient was obviously lying down. I was standing beside the patient on their left side in the beginning. So as they were talking to me, I was standing on their left, standing above them, and this can sometimes be intimidating for the patient. So next time in acute care eval 2, I intend to find a stool or a chair, or I can even kneel down, just to be more on their level so it doesn't seem like they're being talked down to and kind of being approached at a common level. The next thing I wanted to improve on was the organization of the room. Since there is 3 of us in that room at one time, it can sometimes be a little bit crammed, but I've caught myself many times during the eval kind of stopping what I was doing, stopping talking to the patient, grabbing other things and kind of moving them around. Going in, I kind of had a general idea of what I wanted to do with the room, but then once you get in there, some things don't always go according to plan. So just kind of setting the room up for if things do not go as planned, the room is still set up in a way that the treatment can still be beneficial. So for acute care eval 2, I intend to also do that. Another thing is just ensuring that the bed is locked. When I got in there, I kind of got tunnel vision where I just wanted to treat the patient, and I kind of overlooked some of those basic safety things. So when the patient sat back down, the bed kind of rolled a little bit. They were safe, and I was able to keep my hands on the gate belt and make them secure. But the bed was moving, and in future cases or on my clinical, if that were to occur, a patient could kind of slip out from underneath and fall down, which obviously as a therapist, you're at fault there, and there's a lot of paperwork that comes with that, so you do not want to be in that situation. So next time when I go in there, I intend to, the first thing I do when I see the patient is lock that bed in place. The next part that I wrote down was just talking to the patient less. During an eval, you do have to perform the subjective measures. So, getting the patient's pain level, why they're in there, what they've kind of been experiencing, what they've been doing. And I did spend a decent amount of time educating the patient because when asking them some of these questions, they were not completely correct or aware that what they were doing was wrong. So there was a decent amount of time that was spent on education for the patient with their lumbar fusion, but in an acute care setting, your eval is usually not that long. So although some subjective information is important in talking and educating the patient, I do want to spend more time with mobility as opposed to talking. So with the more time with mobility, I can get a better understanding of their gait performance, of outcome measures, of just kind of overall strength in general, because since discharge planning is kind of one of the first things we do and it's very important, I want to spend more time with the mobility part of it to get a better idea of if this patient should be discharged or not. The next part I had was positioning while I was guarding the patient. I kind of already talked to Dr. Haynes about this, but I was a little bit too much. Instead of at that 45-degree angle, I was a little bit more at a 60-degree angle, so I was a little bit more behind the patient. And since the patient was a woman, that can come off a little weird. Obviously, at that angle, you want to be more at a 45-degree. Again, acute care, I'm more worried about the patient falling, so I wanted to ensure that they were safe, which they were, but I could also move kind of a little bit more to the side, and then that way the patient doesn't feel awkward, I don't feel as awkward, it doesn't look as awkward from afar, and we can still perform the mobility and get everything done that we needed to. And then the last part that I had was just allowing the patient to make more mistakes. Because this was acute care and this was a post-op patient, I was very concerned with guarding the patient and ensuring that the patient doesn't fall or doesn't kind of rotate and mess up that fusion surgery that they had. So making sure that the patient is still able to make mistakes while keeping them safe is another thing that I want to improve on going forward.